Thank you to all of you who have joined us. We're absolutely delighted to welcome you to the first Twilight that is being held in February. And tonight we're really looking at our care. We always want to give person-centred care, but tonight we're asking the question, how does care look for me? So we've got a great lineup of speakers. We're Kelly O'Donovan, who is an MFM fellow here with us at Mercy and is now back at King Edward Hospital in Perth. She's asking the question, well, how do you care for me? How do we make sure we provide inclusive pregnancy care for transgender people? Now, our next speaker is Natalie Duffy. She's one of our neonatologists here at the Mercy and is right on the brink of completing her PhD. And her PhD has been in a fascinating area, and it's answering the question that we've posed tonight, well, what's it like for me? What's the lived experience of our care of babies in NICU? And then finally, I'm beyond delighted to be welcoming Dr. Cecilia O'Brien. She's flown down from Townsville to join us. She's also an MFM specialist and did her PhD on fetal growth. Cecilia is going to tell you a remarkable story, answering the question, will you come to me? How do we provide equity and accessible care for perinatal patients in the remote communities of northern Queensland? You won't get any of the book tonight, and thank you so much for joining us. I'd like to start with acknowledgement of country. All of us at Mercy Health, and I know all of you who are joining us tonight who are part of the Mercy Perinatal Village, acknowledge the Aboriginal and Torres Strait Islanders as the traditional custodians of the lands on which we live, we work and we meet tonight. We pay our respects to all elders past and present, and we extend that respect and warm welcome to all First Nations people who might be joining us tonight. We also extend our warm welcome and respect to all the people who are joining us from all the corners of the world. These are just some of the countries who are represented among the thousands of you who have registered to be at Twilight tonight. You are all welcome. We know some of you will be watching live. We know some of you will be seeing it at a more suitable time for where you are living, but you are so welcome and we're delighted that you're joining us. Just a couple of things to note. Next week, we are hosting the Global Obstetric Journal Club from Cape Town in South Africa. We'll have Professor Andy Shannon, Professor Lena Bergman, Professor Kathy Kluver, and of course the Merry Mercy Perinatal Global Obstetric Journal Club team. And we're going to be talking about the paper that has hit the Lancet just in the last few weeks about Prevent PE. That is, can a test and treat program at 36 weeks identify women who are going to develop term preeclampsia? We know about the importance of screening and aspirin treatment to prevent preterm preeclampsia, but term preeclampsia, in fact, is the overwhelming majority of the disease and contributes to the overwhelming majority of maternal morbidity. And yet, efforts to try and reduce term preeclampsia have largely been futile. So this is a hugely important paper, and I think the question we're asking is this ready for prime time? And if it is, what are the barriers that are still in our way? Our next Twilight, if you want to pop it in the diary, is going to come on the 25th of March. Now, we're coming to you from Perth. I know it sounds like we're never actually at Mercy Perinatal anymore, but we actually are. But we're going to be coming straight after Pasans. So some of you might be at Pasans and we'll see you there. But for those of you who aren't, we're taking advantage of the international speakers who are joining us, who have been responsible for the Delphi Consensus on Fetal Growth Restriction. That's about to be updated and reviewed this year. But we're going to join Sunny and Vessel, as well as Adrian Gordon, going to be talking to us about fetal growth restriction from pregnancy to postnatal life. So we'd look forward to seeing you at Twilight from Perth next month, but just remember it will be an hour later than usual, just because Perth is about 3 hours behind. The Future Fellows Masterclass. So all the trainees who are out there, if you are facing the RANSCOG exams over the next year or two, we know that some of the face-to-face learning and masterclass classes before those exams have sometimes been lost a little bit. So we've reinvigorated. We've got a Future Fellows Masterclass, but it's also a great refresh for any of you who are already fellows. I think we've only got 3 spots left. We had to move to a bigger venue, but the bigger venue is now also just about sold out. But if you want to nab one of those last 3 spots, just grab that QR code and we'd love to see you there. It's at the lovely Langham, right on the riverside in Melbourne, and we guarantee you a great few days of learning. Global Midwifery Update is returning to the Park Hyatt this year. As you can see, we've got a fantastic panel of speakers. Not only, of course, Stephen and Ali and Lisa and myself, but also Hannah Darlin is joining us. We've got Natalie Elphinstone talking about maternal-assisted caesarean section, topics about breastfeeding success, optimal positioning in labour, strengthening our response to family violence. So it's going to be a great program. We'd love to see you there at Park Hyatt if you just want to jump on 12th to the 13th of June. And I'm personally very excited to be announcing tonight for the first time our next leadership course. So as you know, we've done day-long leadership programs just about annually over the last 4 years. This time I'm joining with Steve Warrilow, who's the Director of ICU at Austin Health, and we're going to be addressing From Spark to a Flame. How do you ignite your healthcare leadership journey? Now, this is really for everybody. This is for the everyday leaders at the coalface in healthcare. We've got Kirsten Ferguson as our keynote address. Some of you will have read her books. Her most recent one is Blind Spotting, but she's also done Head and Heart in healthcare in leadership, and before that, Womankind. She's just a brilliant, incredibly inspiring speaker, and it's wonderful to hear from leaders who are out of our field. So she's our keynote. Kate Drummond from the Royal Melbourne is going to talk about role models, mentors and sponsors. Who's holding your ladder? What about the first-time manager? What do you need to know? Piraveen was our Director of Medical Services, now the CMO at Cabrini Hospital, and he's going to be saying if you're in your first management position, what you need to know. Leading across boundaries, while we need to be versatile in leadership, how do we guide patients and families through the toughest conversations? So some communication station that's going to be chaired by Bernie Dwyer, who is a nurse who's been the head of the Transplant Organ and Tissue Authority. Anthea Rhodes is going to be giving us an update on social media, and is that light in the way or is it playing with fire? So please, we won't be selling tickets until the end of next week, but if you want to jump on and grab one before they're released, please grab the QR code and do so now. This is sold out every year, so we'd love to see you at Melbourne Brain Centre or join us online. Australian Reproduction Update is returning 27th to the 28th of July. An interesting blend here of Christmas in July, and it's being held at Pentridge. So I don't quite know how those two things synergise, but it's going to be a fantastic couple of days of reproductive science. Go You 2026, the dates are here. Park Hyatt, we're off to Broadway this year. So the tickets will be going on sale very soon, but you can rest assured that we have been at SMFM in the States and we have snabbled up the best international speakers who are going to be joining us again. Just a final call out, we've got the Mercy Perinatal Lived Experience Registry, or MAPLE. If you yourself are a consumer or someone with lived experience, or you've got patients or families who you think would like to contribute particularly to the big research questions that are going to answer Care for Tomorrow, please feel free to get them on board with the MAPLE group. We'd love to have more people joining us if you want to really sort of partner with researchers, whether it's in surveys, research grant development or publications. A final note from me, just as always, we would like to gratefully acknowledge Mercy Health and the Mercy Health Foundation, who enable us to do everything we do at Mercy Perinatal. They're a fantastic organisation. We are so grateful for their support. And of course, if you'd like to know more or if you'd like to support our work, you can scan that QR code. Okay, that is enough from me. It's more than enough from me, I hear you say. Okay, well, let's get straight onto it and make sure that tonight we leave no one behind. What I'm going to do now is pass over. We're going to fly over the Nullarbor and we're going to pick up the next part of the session from Kelly O'Donovan, who's now working as a maternal fetal medicine specialist at King Edward in Perth. Kelly, I'll just stop share and we'll get you to share if you don't mind.
Great, I think I'm unmuted and I hope you can just see a single slide, my PowerPoint. Yeah.
Yes, great. We can. Thanks so much, Kelly.
No worries, and hello to everybody joining online and to everyone in the room in Melbourne. I'm going to talk tonight on gender inclusive pregnancy care. Thank you so much to the Mercy Perinatal team for inviting me to speak tonight. My imposter syndrome is through the roof, but I'm very honoured to be here and to talk about a very important topic. I would like to start off by acknowledging that I'm presenting from Whadjuk Noongar country, and I pay my respect to their elders past, present and emerging, and I extend that respect to any First Nations people joining us tonight. I would also like to disclose that I'm an MFM fellow. I think I was promoted in the program for tonight, but I still have a few months left of training. And I wanted to highlight that this area around gender inclusive care is not specific to the subspecialty of maternal fetal medicine, but I think an important topic for all pregnancy care providers. I identify as a cisgender heterosexual woman. My pronouns are she, her, and I am presenting this data based on some clinical experience, a review of the literature and some community guidance. I aim to present it with respect and inclusivity, and I very much welcome any input, and particularly from those with lived experience. I have no financial or commercial disclosures. So tonight I want to talk about a clinical case describing our experience of caring for a transgender man in his pregnancy. I should note that I've really sort of stripped down this case and removed any identifying information to protect the confidentiality of our patient, given this, still a minority group and only a handful of cases across the country. I'll then touch a bit on some of the literature around transgender patient experiences, and then also provide some hopefully practical recommendations for the provision of holistic and safe gender affirming care. So transgender, non-binary, gender diverse and gender expansive people, which I will group together using an acronym quite consistent across the literature as TGE, comprise a vulnerable group in perinatal care. And studies have shown that TGE people desire to have children with rates comparable to the cisgender population. And in fact, studies show that most TGE people retain the ability to fall pregnant and their reproductive organs. We know that pregnancy among TGE people has increased in frequency and visibility in recent years, but there's actually still quite little clinical guidance and high quality data around perinatal care for this cohort. So our case was for calling patient A as a 30-year-old gravida 1 para 0. Was around 14 weeks when he was referred to a tertiary obstetric unit. He identified as a transgender male. He had previously had a double mastectomy, or often called top surgery. He had previously used testosterone and had ceased this around 12 months prior to conception. He had no recent history of gender dysphoria. He had a complex psychiatric history, but had been stable on typical antipsychotics and was linked in with a perinatal psychiatrist. In the first visit, some important things were established. That his preferred pronouns were he, him and his, that he was comfortable with technical labels or biological terms for his body. This was a spontaneous conception and a planned pregnancy with his long-term partner. Planned parental names and social supports were also explored in this consult. So I wanted to run through some examples of systems issues that arose in the provision of inclusive care for our patient. So one was that our electronic medical record was unable to reflect gender identity and was unable to code the gender identity as being different to the assigned sex at birth. This is a screenshot of the actual warning that came up that our midwife sent to me to say that she couldn't actually create a patient profile in our pregnancy database for this patient. The systems actually only allowed the sex or assigned sex at birth to be entered. And so we couldn't even create a profile for him initially. There was a lack of a gender-neutral patient toilet in the clinical space. A lot of the written information or patient information used very gender-specific language. There was some confusion over the pathology result reporting. So one was the confusion over the sort of registered sex of the patient and the use of gender-specific reference ranges. And in fact, the first time our patient had bloods collected in the pathology lab, he received a call later on from the lab to confirm his identity and asked if he had attended to get some blood samples with his wife. So that led to a bit of an awkward conversation. There were some various assumptions made from staff at different points that led to some awkward encounters. In fact, most of this was from non-clinical staff. Our patient shared some interactions with us, and one was, an orderly came to pick him up to take him for some investigations, and there was some confusion from the orderly asking where the patient was and asking if the patient was actually the patient's partner. Another example was that the catering staff were a bit confused and denied the patient a meal, saying that the patient's partners were not actually eligible for a meal. So in order to improve the patient experience, various actions were undertaken. There were many meetings and huddles between key members of the leadership and management team. And this initially started down as quite a top-end approach. The meetings involved the Director of Clinical Services, the Medical Services Director, Unit Midwifery Lead and Social Work. They mapped the patient's journey through the service in anticipation of what they might need and where they would have clinical encounters. And then under the direction of the unit leads, they were involved in educating their staff, providing some preparation and awareness for their staff in areas that the patient would come through. And a big component of this was engaging non-clinical staff. So admin support and then patient services unit was involved in the education, as well as environmental services who helped to create some physical change to make the environments more inclusive. Of course, IT were on the phone many times to try and change our administrative systems and our clinical our electronic medical records. To get through some of the pathology confusion, there was an alert placed on the patient's UR to document his transgender male status. And with the patient's consent, we documented on the written request forms a transgender male patient and then some other clinical information that was relevant. A complex care plan was documented and circulated to relevant stakeholders. And an article that I'll touch on in a bit was circulated on multidisciplinary care for gender diverse patients, was circulated and actually uploaded to the patient's electronic medical record. We liaised with the operations team to change some signage in the corridors and create an all-gender toilet. And it was proposed that long-term we should develop some consistent policy to support consistent practice for future care for gender diverse people. The patient received multidisciplinary team care, so obstetrics, midwifery, perinatal mental health, physio and social work. As is consistent with the literature, one-on-one antenatal classes were arranged. He chose an MGP model of care, and this aligns with a lot of the data that comes out of the US, with the midwifery model of care being preferred. And I guess we know there's so much more data around about the benefits of MGP care for all patients, but particularly for those from minority groups or vulnerable population groups. A birth plan and postnatal feeding plan was made. The patient had a birth suite tour around 34 weeks of gestation, and particular attention was made in their birth plan for a plan around genital exposure and genital examinations. And a postnatal feeding plan was made as well. The patient went into spontaneous labour, had a normal vaginal delivery of a healthy baby of a normal weight. Postnatally, was debriefed, he had a marina for contraception and was linked back in with his mental health team for ongoing support. So the conclusions of the case was that there was some good outcomes and a really positive experience was reported from the patient and his family. I think for me as a fellow, this was a great learning experience and an example of effective interdisciplinary collaboration to ensure patient-centred and individualised care. The case prompted system and environmental changes in the units, and it improved a lot of knowledge and awareness of gender inclusion perinatal care. Looking at some of the literature, it's quite clear and consistent in numerous studies that TGE people face discrimination, stigma, neglect and poor treatment in healthcare. And it's also known that they're less likely to obtain preventative care. One US survey, not specific to the perinatal population, but all transgender and gender diverse patients, almost a quarter of participants avoided seeking medical care due to fear of mistreatment. Pregnancy particularly increases the chance for gender dysphoria and loneliness. Many trans men are sort of confronted with the fact that they still have, a uterus, vagina, and they find that this increases their chance of, or increases their gender dysphoria. And there are many barriers discussed in literature around access to quality perinatal care. Those include institutional and individual erasure in perinatal health care. We've touched on some of these components already, but things like healthcare practitioner bias, lack of awareness, incorrect assumptions, was the IT systems. The US data talk a bit about how in some states there are issues around birth certificates and putting different genders and sex of parents on birth certificates. And also out of the US data, interestingly, in some states there are insurance implications because they refuse to provide healthcare or private insurance to patients that are choosing to have a different gender than their assigned sex at birth. The other aspect of erasure is the exclusion of transgender people in research and audit, which impacts outcomes quite significantly. We also know that the provision of childbirth-related care is really geared towards heteronormative, and this is sort of evident in our clinical spaces, the language that is used. In some of the qualitative data, patients talk about the difficulty even finding pregnancy-suitable clothes that are not suitable for people wanting a masculine appearance. And there's a lot of data around issues with breastfeeding, which I'll get to, and people being really fearful for feeding in public. The data around perinatal outcomes is actually quite limited. Most comes from case studies and cross-sectional surveys, and there's actually very limited high-quality data in this space. We know from US data that when we look at the locations of care, that transgender men had mainly chosen midwifery models of care. One series reported that about 40% of patients chose an obstetric-led model of care, which is quite unusual in the US system, and about 20% of patients had a home birth. The mode of delivery data supports that the majority of trans men in the published literature delivered vaginally, or some people prefer the term delivered genitally. In a large 2020 survey, sorry, something is beeping on my computer. In a large 2020 survey of about 200 trans men, about 77% delivered genitally or had a vaginal delivery. The data looking at obstetric complications and severe parental morbidity comes mostly from the US, but they report really quite similar rates of obstetric complications when comparing transgender patients with cisgender individuals. This table is from a 2023 study by Stromset et al., and they looked at outcomes in two large databases, so the Medicaid database and a commercial insurance database. And they compared over about 1 million cisgender patients and their pregnancy outcomes with a few thousand patients or transgender patients and their outcomes. They didn't find that there was a statistically significant difference in severe parental morbidity, which was their primary outcome. The data is a little bit difficult to interpret because of much lower numbers of transgender patients. They did find, though, interestingly, although this was a secondary outcome, that there was a trend towards lower odds of caesarean section delivery in trans patients compared to cisgender patients. Across the literature, it's quite clear that there is an increased risk of postnatal depression, about 35% in many cohorts, and this kind of aligns with data supporting a higher chance of pre-existing anxiety and depression in these patients. I think the qualitative data in this space is really important to look at. This is a really nice study that was conducted in the Netherlands by Amersfoort et al., and they published 5 in-depth interviews with trans men who had pregnancies. Some of the themes that they found really helpful included a healthcare practitioner openness and willingness to learn. They felt that feeling seen, being heard, and acknowledgement that their wish to carry a pregnancy was as normal was really helpful. Confirming pronouns and labelling of body parts, not saying constantly that their cases were unique or special, and one participant described feeling frustrated that they kept being called a pioneer. They found sharing pregnancy experience with other gender diverse people very helpful and being linked in with support groups. And many participants talked about various books being helpful, and I've put up some screenshots of some books that patients found helpful. Trevor McDonald particularly has published a lot in the infant feeding and chest feeding space in the medical literature as well. Just touch on language briefly, because it's really important to be familiar with sort of gender neutral terms that are very different to the cisnormative language that we always use. And this can be tricky. I mean, I think I've already said breastfeeding at one point in this presentation, because we're so used to using the cisnormative language all the time for our patients. But it's really important to be mindful of using language that would be more preferable to our patients. So particularly in the perinatal space, many gender diverse individuals would prefer not to use cisnormative language for vagina, vulva, and penis, and they would prefer to use neutral terms like genitals. Some would prefer to use front hole or pelvic organs. And it's just important to have that conversation with your patient to see what their preference is around this. Feeding is another example. So the gender neutral term for breastfeeding is chest feeding. Sometimes human milk feeding or infant feeding is also a neutral term to use. And I think many of us here do a lot of ultrasound. It's important to get the language right in this setting, and rather, referring to genitals and the fetal sex rather than assigning any concepts of gender or the baby's in utero. And the language in this space is very important. This is a really lovely study by Monica Hahn et al. And it was the study that we actually circulated for the team of clinicians caring for our patient. It provides a lot of practical support and suggestions, and it breaks down breaks everything into different areas. So they have a certain section on, making sure there's a safe environment, and advice around the non-clinical aspects of care in terms of admin, IT, legal aspects. And then it breaks the provision of care up into the preconception space and then into antenatal, intrapartum and the postpartum space. In the interest of time, I won't go through all of this article, but I wanted to cover a few specific areas. So looking at the preconception space and talking about testosterone. So testosterone is used as gender-affirming masculinizing hormone therapy, and many trans men or gender-diverse individuals will opt to use testosterone. The recommendation is to stop testosterone therapy before conception, and this is due largely to theoretical concerns, but to the potential for the androgenic effects on the fetus with high levels of testosterone use in pregnancy. The optimal time is actually quite unknown and unstudied of when to cease the medication, but the international standards of care say for at least about 4 weeks. So this is the general consensus on advice. The data on this is quite minimal, but I think it's reassuring to talk to patients about the fact that testosterone use before pregnancy has not been seen to impact on fertility and perinatal outcomes. It's also really important to know that cessation may exacerbate depressive symptoms and gender dysphoria, and to ensure that your patient is adequately supported and linked in with psychological supports when coming off this therapy in preparation for pregnancy. In the postpartum space, I wanted to talk about newborn feeding. So it's really important to have a plan made antenatally and ensure that the patient feels well supported and has all options discussed with them. The data on this is quite variable. It's the small case series report about 50 to 70% of trans men in these studies have chosen to chest feed. But it's very variable, and for many trans patients or trans men, this can be a particular trigger for gender dysphoria. So really, it's considered by many as quite a significant gendered act, and many will choose to suppress feeding, to suppress chest feeding. It's important to know that even if the patient has had top surgery or a double mastectomy, they may still experience some chest growth plus or minus lactation, and to have a plan in place for support if this happens and lactation is not desired. Linking people in with a lactation consultant has been very beneficial in a lot of the literature, and the qualitative data on this does mainly support that many men chose not to chest feed because they felt a lack of support. Weren't linked in with the lactation consultant, and felt quite fearful of feeding in public. discuss various options of lactation suppression with patients, so pharmacological, non-pharmacological measures, and the other thing to sort of discuss as well is if some trans men will choose to utilise chest binding, and it's important to go through this. They may need to make some adjustments to how they're chest binding, because it can increase the risk of stasis in the breast tissue and mastitis. There's actually very limited data on testosterone in lactation. At the current step, at the moment, currently, the recommendation is to stop testosterone or to avoid using it in lactation. The very minimal data available does support that there's actually a really low amount that's transmitted in the breast milk, but the overall recommendation is to avoid it just because of insufficient data. It's definitely recommended to avoid it until the milk supply is established, and then to discuss risk-benefit balance with your patient. Other recommendations for postpartum include ensuring the correct documentation on birth certificates. If patients choose not to chest feed, you can restart testosterone around 4 to 6 weeks post-delivery. There's no good data on this, but it's been extrapolated from the advice we generally give around recommencing the COPCP, given the similar increase in VTE risk postpartum. It's really important to know that testosterone is not a reliable form of contraception, and there have been many unintended pregnancies reported on while on testosterone use. So talking about reliable options of contraception with patients, so progesterone only is a good option. It's not thought to interfere with masculinization or continuing on testosterone. Important, as I've mentioned already, to link patients back into their community support and psychological support postpartum. So where to from here? I think it's very clear that we need a lot more data and a bit more local data. A lot of the data published is available from the US. We need to adopt gender-inclusive research practices, capture more patient experiences, and clearly keep working on some system and environmental changes. I always like the Mercy Talks when they provide some really practical suggestions for what we can change when we get to our office today or tomorrow. And I've just got some 5 points that I wanted to make in relation to that. I can't take full credit for this idea or these 5 points because I've adapted this from a brilliant talk given by a Dr. Justin Brand, who's a professor at NYU who talks beautifully on this topic in the US. But point number 1, so introduce yourself to patients with your name, title, and pronouns. A really simple way of doing this is to wear a little name badge with your pronouns, adding your pronouns to the signature of your emails, and particularly in patient-facing correspondence, ensuring clinic registration forms have multiple gender options and the ability to link this in with our IT administrative systems. Be mindful of gender-neutral language to use in the perinatal space. And then just know where to find some good resources. And I'll highlight a couple going forward. This is just a shout out to one of my colleagues, Dr. Sheba, who I work with here in Perth. She's organised these badges for all of us trainees. And she was really quite inspired to do this after she heard a talk at one of the Ranscock ASMs from a queer couple who spoke about their pregnancy journey and had noted that there wasn't a lot of queer support visible in the environment that they were in, and they thought that this would be quite helpful. She was also quite motivated after a video that she saw by Oslo Pride, and I've put up the QR code here for anyone who's interested, as it really just emphasises the importance of these small gestures and symbolism in making people feel comfortable in clinical and non-clinical settings. And I'll come back to this QR code in a bit. So there are quite a lot of resources if you get onto Google, but I thought this Resource Trans Hub was a good go-to place to go. It is an Australian website. There's a link also from here to Melbourne Uni if you're looking at trans-inclusive research practices. But this site really, it's got great information for trans people. It's got wonderful information for clinicians, and there's a bit down here at the bottom for fertility and reproductive health. So it's a really great go-to guide. There's lots of information also about creating safe environments, the languages to use, what questions to ask. So for me, this would be a great go-to reference when you're faced with a gender diverse patient. Rainbow Families has lovely resources for families seeking pregnancy. There's some great posters that midwives can use and put up in perinatal settings that are inclusive. Finally, so this very quickly, just to touch on this is a lovely guide for employers to use to ensure that their office or their environment complies to make it a gender inclusive and safe environment. So I'll end it there. I think I've just gone 20 minutes and I would like to make a couple of thank yous. One is to our patients for sharing their experiences with us so that we can learn and improve. The other is just to thank the team that I worked with on the case that I presented. I can't be too specific to protect confidentiality, but you know who you are, and I learned a lot about providing patient-centred care. I'm very happy to have any questions.
Kelly, thank you so much. That was a fantastic talk. Sorry, I know it looks like I'm looking out the window all the time. It's just the screen's in a different place. Kelly, thank you. That was a really very helpful talk. And I sort of feel like in some respects, maternity care has had to take the leading edge a little bit in this because the demographic that we are serving, I suppose general hospitals have it as well, but the majority of our population expect that we will have very good literacy in this area. And it's advocates like you that ensure that we do become much more competent in providing care, but also just in inclusivity for all gender diverse people. Kelly, it is quite shocking to me that you said 25% of transgender people report not accessing medical care, and that's borne out by the literature. And in fact, that's a very high number really compared to any other minority group. I'm wondering, what do you think the opportunities and barriers are for us? Because if there was any other group where we said 1 in 4 of those group will hesitate to seek any pregnancy care, we would be being very proactive to try and make sure that we made sure the hospital was a safe place for them to feel like they could have care. Do you think that we need to do better outreach, both in the pregnancy but also in the postnatal and feeding space?
Yes, I think so. I think it's complex and it's multifactorial, and I think hopefully things are changing over time, and we'll see, and people are being more inclusive in general in the community, in our hospitals. I think people are more mindful about inclusivity, and hopefully we'd see those statistics dropping. But I think it'd be targeted from multiple facets, and I think I think we've got to engage with community and outpatient clinical settings to help bridge the gap between those settings and the hospital environment, because I know that in the metro, and I think it's also like, I know in the metropolitan settings, certainly in places like Melbourne, there are a lot more sort of trans-friendly GP practices and specific clinics being set up to target this in the community, but not necessarily in the hospital setting. So I think that the interface between those two areas would potentially help to bridge that. But I think just small things to start with as well, just making people feel welcome when they come and willing to open up to disclose all of their past and their history makes a big difference. And that's even just, like I said, the small gestures of changing our badges and having inclusive symbols in a clinical environment will hopefully help to make people feel safer. But it's probably not a one answer fix. It's complex, but overall, yes, I do. I think we need to be trying harder to reduce those numbers.
Yeah. And it does sound right that reconnecting both with primary care, particularly with the people who've got expertise and interest, who have a particular transgender care interest, is a good way to go. And perhaps also for some of the transgender care clinics, we should be also reaching out a bit proactively about if you are thinking about a pregnancy, so that they understand that we are wanting to provide the information and the care that they need. I think Ali's got a question.
Yeah. Thanks, Kelly, for such a great talk. I have a question, and I know you're not the expert, but maybe in your readings you might have come across this. Do you know how much effort has gone into providing more education to people in training? Because of course we're all quite late coming to this, but there's medical students, midwifery students, nursing students, and if this is part of the general education up front, it makes it a little bit easier that they're knowledgeable and prepared much sooner rather than us learning off the back foot.
Yeah, it's a great point. I think, there's clearly in the literature, there's clearly a lot of talk about the need for this. There's no data that evaluates the success of these programs in a university setting or in our training programs. And to the best of my knowledge, I don't believe there's anything for us RANSCROB trainees, for example, yet. I think it would be a good space or a good module to create in our online learning. I do believe that there's some more teaching on this in medical schools, but I don't have I've heard this anecdotally, but I don't have the formal numbers around this. But I'd say there'd be hopefully, and I think there's a lot more there's a lot more work going on in that space.
Yeah, that's absolutely true, Kelly. It is sort of being built into curriculum a little bit more, but you're right that I think RANSCOG and ACMI, I'm sure, either are or should be looking at guidelines, and I can hear them ringing your phone right now. So please pick up. That'll be Nita.
Sorry, the other point, sorry, Sue, just for your first question, I just was thinking about what I think also ensuring that people not living in metropolitan centres have access to this care is utilising telemedicine, and that could be the way to help improve access to care for patients in this area. Yeah, very good point. Sorry. Kelly, amazing. Thank you so much for a lovely talk. I know it's the middle of the afternoon over there and we've probably dragged you away from clinic, but we make no apology for that. Thank you so much for joining us. I hope you can stay on for the rest of the session, and please keep an eye on the chat. If there are questions, please feel free to answer them as you go. So thank you. It's an absolute pleasure now to hand over to Dr. Nat Duffy, as I say, one of the neonatologists here, just completing her PhD, and she's going to talk to us about what is care like for me, the infant's lived experience of hospitalisation in NICU. Thanks, Nat.
Thank you for introducing me and for inviting me to be here and for including the baby's voice when we're talking about leaving nobody behind. So we're going to talk about the experience study, which is my PhD. Okay, so the experience study rests on 3 core principles, which are each informed by decades of research and theory. The first is that brain growth and development are shaped by early life experiences. The second is that infants experience their world through a complex system of relationships. And third, infants communicate their thoughts, feelings, and experiences through their behaviours, cues, and states of alertness. And these principles are particularly evident in the NICU, where every experience, both positive or negative, shapes the developing brain. So neonatal intensive care is essential for survival, and our models of care continue to evolve with a shared commitment to improving outcomes. Yet despite these advances, the NICU remains unlike any other environment for a newborn baby. And hospitalisation in the newborn period shapes how infants perceive their world and form their earliest relationships. And it's within this context that my study emerges, which is to understand the NICU not through a clinical lens, but through the eyes of the infants themselves, centering their voice, so that we may shape care that truly responds to their experience. So the experience study aim, as we've talked about, is to understand the infant's lived experience of hospitalisation in neonatal intensive care. So to begin with, I reviewed the existing literature to understand what we already knew of the infant's experience. And this published paper draws on 23 studies. And what really became clear is that their experience is explored predominantly through quantitative methods, with a strong reliance on measurable outcomes as proxies for how an infant's experience might be felt or processed. And this links into what Kelly's just talked about. So whilst that work is essential, it became clear that we need to try to understand neonatal care through a different lens. so that we can actually understand how it's lived and processed. So that gap drew me towards qualitative research, which are approaches concerned with meaning, context, and lived experience. And I began to consider whether these methodologies might give that different lens, not in place of quantitative data, but alongside it. And so I was introduced to phenomenology. Phenomenology is a qualitative approach that's concerned with lived experience, with understanding what an experience is like from the perspective of those who live it. Rather than explaining or measuring phenomena, it asks a different kind of question. How is the experience perceived, felt, and embodied? How is it made meaningful? So importantly, the aim is not to catalogue individual differences, but to attend to what is shared, to the underlying fundamental human condition. And for me, this offered a way of thinking about how infants in the NICU and it aligns also with my clinical intuition that experience matters, even when it cannot be spoken. So if you just look at some of these really powerful pictures of babies that are clearly communicating their thoughts and experiences to us by using their behaviour as a way of understanding experience, I developed a novel methodology to address the study aims. We called this methodology 360-degree phenomenology. So 360-degree phenomenology uses a mix of data collection methods designed to get as close as possible to the baby's experience. I started by focusing on the infants themselves, spending time at their bedside, observing their everyday experiences, immersing myself in their world, noticing what they see, hear, and feel. I watched how they interacted and connected with their caregivers and took in the emotional and atmosphere surrounding them, thinking what it might feel like and be like from the infant's perspective. For the times when I couldn't be there, I invited parents and staff to keep bedside diaries. And I also used the Newborn Behavioural Observation System, or the MBO, which is a relationship building tool to allow me direct interaction with the infants in the study, to gain deeper insight into their behaviours and their communicative strategies. And finally, to triangulate all the infant data, I conducted semi-structured interviews with parents and staff, asking them to put themselves in the infant's shoes and articulate what these experiences might feel like from the baby's perspective. The study took place in a quaternary NICU in Victoria, and I recruited term infants with an expected hospital stay of more than 7 days. Infants were excluded if they required cardiac surgery in the newborn period, purely for pragmatic reasons, because those babies are co-managed between different departments, and if the infant was on a palliative care pathway. I observed the infant's experiences for the duration of their hospital admission, or for a maximum of 12 weeks. Because this was an in-depth qualitative study, we were guided by the principle of information power, prioritising rich, relevant data rather than large participant numbers. So on that basis, we enrolled 7 infants and 37 of their adult caregivers into the experience study. This involved over 100 hours of direct infant observation, 17 diaries, and 11 formal MBO sessions. I also conducted 40 semi-structured interviews with adult caregivers, with parents invited to participate in 2 interviews if possible across the study period. The data was then analysed using the 6 steps of Braun and Clark's thematic analysis, which is a well-documented way of analysing qualitative data. I organised the findings into 3 main results papers. The first gives an overview of the infant's experience across 3 interconnected domains: physical, emotional, and relational. And then papers 2 and 3 look more closely at the infant's relational world, meaning all of their interactions, connections, and relationships that shape how they experience life. As I've just outlined, the findings illuminate the infant's experience in NICU across 3 deeply interconnected domains: physical, emotional, and relational. These domains don't operate independently. Instead, they continuously shape and influence one another. For example, during a clinical procedure, the infant's body is physically touched, creating a sensory experience of pain. That may then evoke distress, and at the same time, the relational context of that moment, who is present, how they respond, and how interactions unfold, shapes how the infant feels in that moment. Hence, the relational domain acts as the anchor of experience. It's through connection with healthcare professionals and relationships with their parents that other aspects of the NICU experience are mediated, regulated, and given meaning for the infant. So I'm now going to briefly take you through these domains of experience. Along the way, I'll share examples of infants' behaviours and include quotes from parents and clinicians to illustrate how I interpreted the data and worked through the analysis in an iterative way. This work, similar to what Kelly's has discussed, is deeply emotive. It's not a critique of care, but it's rather an opportunity for us all to reflect and to learn together. So, my physical world explores the infant's physical surroundings and how these shape their early experiences. This includes not only the environment, but also their sensory experience and everything that's done to their bodies as part of their care. There's an inherent tension within the NICU. On one hand, it's the ultimate safe space. It's a place where a child's life is saved. But at the same time, it can be scary, unknown, foreign, even hostile. Words used by adult caregivers to describe the infant's environment. Infants experience sensory overwhelm and ongoing commotion. People, medical equipment, and the sounds of care surround them and touch them, often in ways that can be intense and unfamiliar, other words given by adults in the study. This leads directly into the sub-theme of all these hard things, all the procedures, interventions, and handling that are done to them. It's about capturing the reality of what infants physically endure in the NICU and how it shapes their early experience of the world and therefore the impact these experiences may have. So I'm just going to read you some of these. The monitor is alarming, so too is the ventilator. The suction equipment gurgles as it's passed down the breathing tube. He is rendered silent by the breathing tube, but his posture, his frown, his colour all portray his feelings. When we first came and saw him, he was just needles and tubes everywhere. He was so new in the world and to have had so much done to him. It's so intrusive, it's just awful. We now turn to the emotional world, which captures the emotional roller coaster experienced by the infant. There were moments of peace and rest, times when they could just be undisturbed and secure. I also witnessed interactions that brought happiness and joy, moments like skin to skin, cuddling, story time, and singing. During these interactions, infants were relaxed, alert, and engaged with their adult caregivers, sharing eye contact, vocalizations, and showing a sense of curiosity, eager to learn about the social world around them. So from one of the MBO sessions, as she locked eyes with me, following my face and my voice, we could see her eagerness to connect, her response to the red ball and rattle, which are two pieces of equipment we use in the session, so a similar keenness to explore her world. Alongside moments of joy and curiosity, infants in the NICU also experience anxiety and fear. Clinical procedures, the handling that they require, and the presence of many unfamiliar faces and hands can be overwhelming. There's bright lights, loud noises, and sudden movements can contribute to a sense of uncertainty and stress. In these moments, infants may startle, cry, or become tense, behaviours that clearly signal their discomfort. These responses are then interpreted and described by adult caregivers as expressions of fear or anxiety. Her arms are contained within the blanket, but she's kicking and arching her back. Her heart and breathing rate have risen steadily since the procedure began. The monitor sounds its alarm. She changes colour, becoming mottled around the mouth. Her legs stiffen again, extending outwards. As the tube is inserted into her nose, she cries out, and then her entire body goes limp. Separation from their parents is one of the hardest experiences for infants in NICU. Being apart from the person who provides them with safety, love, and comfort can leave a baby feeling lonely and vulnerable. Even when cared for by kind and attentive staff, the absence of a parent is deeply felt, shaping the baby's emotional world in profound ways. I think it must be awful to be alone, to be lonely and by yourself in this place. So now we turn our attention to the infant's relationships and how these shape their experiences of neonatal care. The focus of the second published paper is the infant-parent relationship, and the stage on which this relationship unfolds is complex. It's shaped, as I've just mentioned, by separation and compounded by an altered parenting role and diminished parental confidence, topics which were discussed at length in interview. Moments of uncertainty and missed opportunities for connection are common, influenced not only by medical fragility, but also by the physical environment, medical equipment, medications that alter how infants can communicate with us, and at times hospital policies and cultural norms that limit opportunities for closeness. I want to be able to, just pick her up, but just to pick her up and comfort her with all the tubes and everything, that is obviously really difficult. Then they leave. Then the nursing staff would pick up the baton for the subsequent, what would it be, say 16 hours potentially, from when mum and dad leave to when they return the next morning. They tried to continue, but they will never be able to do the same job as her parents. I always found leaving him at night was the hardest part, putting him down, knowing I'm not going to be here through the night for you. But despite these hardships, there are also powerful moments of meeting and connection, times when infants and parents come together. In these moments, infants are not just surviving, but they're thriving within the NICU environment. Sarah lies in her cot as her parents prepare to take her 7-week photos. The space is calm, quiet. Her parents speak to her in animated tones, smiling and adjusting her blanket. Sarah is awake and alert, her eyes wide and tracking between their faces. She lifts her eyebrows and opens her mouth slightly, her gaze steady and responsive. I didn't like being undressed today, Daddy. I got upset and started to fuss. But you spoke to me softly and held my hands close to my chest. With your calm voice and gentle touch, I was able to settle. And finally, paper 3 explores the infant-clinician relationship. The NICU operates at the intersection of two essential but at times competing goals: the preservation of life and the promotion of optimal infant development. Care is understandably centred on the infant's physical health. However, this focus can inadvertently limit attention to the infant's emotional safety and their early relational health. In this first sub-theme, the complexity of relational dynamics, I illuminate how each individual infant is exposed to many clinicians throughout their NICU journey. And this brings inconsistencies in approach within and across disciplines. The interactions varied in frequency and focus, voices differ in tone and volume, and handling varies in intention. From the infant's perspective, there's a constant shift in landscape of engagement, care, and attention. All these unfamiliar faces and hands touching you, like lots of people have handled him over the last week. All these different nurses, day and night, night and day. That must be really hard for him. We must also intentionally consider the infant's personhood, their identity, and their presence within the relational space. Infants are active participants in interactions. Their cues, behaviours, and expressions make meaningful contributions to the relational exchange. I observed moments of attunement and intimacy, shared gaze, reciprocal body language, and gentle verbal and non-verbal communication between babies and staff. These interactions can have a meaningful impact, shaping the infant's emerging sense of self, safety, and regulation. And this is shown here. He's in a quiet, alert state as the doctor enters the room. She approaches him, speaking softly. In response to the sound, Henry stills, listening and locating her voice. He turns his head towards her. A greeting is exchanged, brief but intentional. The doctor extends a finger. Henry reaches and takes hold. But in contrast to moments of synchrony and attunement, there were also times when infants' cues were overlooked, when care was delivered to rather than with the infant. In some interactions, babies were referred to by their condition or bed number rather than by their name as conversations took place around them. Tasks were carried out with great technical skill, but sometimes without eye contact, comforting touch, or words directed to the infant. And during these times, the infant can become peripheral to the interaction, the necessary site of care, but not an active participant in it. And these moments remind us that even within the demands of critical care, connection is central to how an infant experiences the care we provide. As the team prepare to leave, a passing concern about jaundice is raised. Without pause or warning, Charlie's blankets are pulled back to assess his skin tone. His reaction's immediate. Startled from sleep, he extends his arms and legs in a rapid, disorganised motion. Signs of physiological distress follow. His heart rate increases, breathing becomes erratic, and his face flushes. He turns sharply to the right, tugging at his endotracheal tube. People would do their jobs, but not necessarily talk to him. Notice him as a little person to talk to. The baby is in the middle of it all and often forgotten. Finally, healthcare workers describe systemic pressures, emotional demands, limited training in infant mental health, and uncertainty about their role in supporting this as real barriers to providing holistic care, ultimately impacting the infant-clinician relationship. I guess people are putting all their energy into their ABCs and keeping babies alive, that the other stuff is seen. I don't know, maybe there's just no capacity for it. I think it's a really important part of all of our jobs to be thinking about her experience and doing your best within your role to support that. So overall, the infant's NICU experience is complex and demanding. It's shaped by intertwined physical, emotional and relational dimensions. Physically, infants were exposed to life-saving care, but also to pain, discomfort and sensory overload. Moments of togetherness, as observed during skin to skin, brought a sense of calm. Emotionally, their behaviours reflected both stress and vulnerability, as well as moments of regulation and emerging capacities for engagement. Relationally, connection with caregivers through touch, voice and attuned presence consistently emerged as a protective and organising force. So as I've just outlined, infants experience the NICU as demanding and complex. Their experience requires continual adaptation to sensory, procedural and relational challenges. Across the data, their behaviours consistently expressed how they were physically feeling, emotionally coping and relationally responding to both the environment and the people around them. These findings affirm that infants in the NICU are not passive recipients of care, but active meaning-making participants with a subjective experience, calling us to engage with and reflect on that experience. Importantly, the presence, attunement and quality of connection offered by parents and clinicians shaped how infants navigated these demands and their capacity to cope. And by interpreting infants' expressions as meaningful communication, this study demonstrates how the infant's voice can and should inform care. So, having shared what I've learned about the infant's experience, the next question becomes, what does this mean for neonatal care? The findings are not merely descriptive, they have clear practical significance, and they invite us to reconsider how we recognise and respond to infant cues, how we support the parent-infant relationship, and how we as healthcare professionals see and connect with the infants in our care. Whilst the work focuses on the infants, the findings make clear that infant experience cannot be understood in isolation. Just as physical, emotional and relational domains of experience are interconnected, so too is the context in which they unfold. Infants' experiences are shaped through ongoing interactions and the quality of connection with the adults around them, whose presence, attunement and actions influence moment-to-moment care. Taken together, these findings highlight the power of connection as a unifying and protective force. This perspective not only deepens our understanding of the infant's experience in NICU, but also brings into view the lived realities of parents and staff. Connection cannot flourish unless we attend to each person's life world, creating space to truly listen, understand and respond. And whilst I've outlined the many disruptions within the NICU that can challenge this model, I also hope I've illuminated the moments of meeting and connection and the profound difference they made. And it's this understanding that I offer as guidance for shaping the next phase of neonatal care, care grounded in connection. And the diagram that you can see here, it represents a conceptual framework, an idea grounded in experience and evidence, but not yet tested. So the next phase of my research career, therefore, involves working directly with infants, parents and staff to co-design a model of connection-based care, remaining faithful to the qualitative methodologies that I've come to know and love, ensuring that the voices of those who matter most are placed at the centre of the work, to ultimately, I hope, improve outcomes for all. So in conclusion, early experiences matter, To provide truly responsive care, we must centre the infant's voice and recognise their personhood. Infants aren't passive recipients of care, they're communicating, experiencing human beings. When we listen, care becomes more relational, more connected, and more meaningful. I'd like to take the opportunity to thank the babies, their parents and the staff in the experience study. Their bravery and their honesty has really was truly humbling, and I'm greatly indebted to everything that they've taught me, and hopefully we can now go on to teach other people to listen to the baby's voice and centre the baby's voice. Thank you very much for having me.
Matt, thank you. That was an extraordinary talk. I've heard you speak of some of this before, but congratulations on your PhD, and it's such important work. I was going to ask exactly that, the what's next piece. Tell me about what that implementation framework looks like and how you are going to test and measure its effectiveness.
So I appreciate that just rolling out a whole new model of care is not easy. So the first thing we're actually starting with is identifying, using a small wins framework, small tangible changes that can happen today, that we can make changes such as always using the baby's name when you're interacting with them to give them a sense of personhood, to allow the parents to realise that they are more than a bundle of pathology, and to help to staff to understand the relational connection around the baby. So we're identifying small wins that we can put into at the coalface straight from the beginning. And then, as I've said, I would like to co-design a model of care based on connection, understanding what the real needs of all members of that relational triad, baby, parent and staff. But that's going to take a bit of time. The experience study gave us the baby's voice, and I also now trying to bring that into the literature and put it alongside what's published. There are clear enablers and barriers to connection-focused care. And underneath what lies behind those barriers, I think, is education. Reflective supervision. I had the privilege to have a lot of reflective supervision in this PhD, and more psychological support for baby, for parent and for staff, and bringing those. So we're looking at educational frameworks and trying to centre the voice of some of our colleagues who are already greatly experienced, our social workers, our allied health professionals. And I am hoping that this will be there's a call in the literature that we know that we can do better for babies and families. And I think often the staff are left behind. And I'm hopeful that we can combine a way where all members of that triad have a voice.
Thank you. That's so powerful. I mean, beware the quantitative people. But like like where some of these interventions you say have been successfully implemented, has it translated to shorter lengths of stay or improved physiological parameters or lower inflammatory markers or any of those things which sometimes can be quite compelling for funders and whatever else who are concerned about length of stay and cost of care?
So Skin to Skin is internationally recognised. That is the baby's number one home. If you look at this baby, that in this picture, this still photo here, that baby would rather be held on the chest of their parent. And there's huge literature out there that Skin to Skin reduces hospital stay, reduces infection risk, increases breastfeeding rates, improves mental health for parents, improves job satisfaction for staff. But there's barriers to providing care. Models of care which have been established and have been around for decades also look at similar outcomes and prove that there is benefits to relationally or infant-led care or family-centred care. But the application of those models are inconsistent. They're very resource intensive, and they're not equitable around the world, depending on where you're providing the care. So I think if we can perhaps work together and include all that fabulous work and move into the next era and think about connection, because connection makes sense to everyone.
Yeah. And I love the low-hanging fruit that you're talking about, like just using a baby's name. It seems like such a simple intervention, and you can't help but think that the nudge of saying, so William, we're going to take a blood test, probably reframes that whole interaction.
Absolutely.
So I love that. And sorry, I'll stop talking in a second. But translatable, because you've done it in term infants.
Yep.
Is the plan to look at it in preterm and see if you have the same experience, or would you just do a copy paste and say we would expect that the same sort of infant-centred care would have the same benefits, even though those babies are less mature?
If I could rewind the clock back, I wouldn't have just included term babies, but you know, what you're going to do.
Welcome to every PhD.
Welcome to every
Anyone's
PhD.
ever done.
And there's a lot in the literature about preterm babies not having the same behavioural repertoire as a term baby. Humbly, I disagree. They have the same behavioural repertoire. It's just that it's a little bit more difficult to read. So that takes us back to education and understanding these cues. But I think ultimately I could do this experience in a perinatal centre with preterm babies, and a lot of the experiences that their term peers have had and I've documented would be very much the same for the preterm baby. And there's lots of literature to support how traumatic the environment is for preterm babies and the developing brain. So I think that although this is only the voice of term babies, it can be thought of as representing a hospitalised newborn.
Well, thank you so much, Nat. That was just a brilliant talk, a completely different perspective of a group that we definitely don't want to leave behind. So thank you.
Thank you.
And finally, I'm going to ask Cecilia, who I mentioned at the introduction. She's a maternal fetal medicine specialist. She's based in Townsville. She too has gone through the journey of her PhD, but her work now is quite different to that cool ivory tower of academia. And she's going to talk to us about Will You Come to Me? What about equity and access in perinatal care? So thanks, Cecilia.
Thank you, Sue, and thank you to the Mercy perinatal team for inviting me to come to the lovely Melbourne. So I'd like to just run through a little bit of an understanding about the disparity when you look at health and perinatal statistics in the north compared to the south. And really, what was the beginning of the outreach program, what it is, how do we do it, and what is the future? If you draw a line across the Tropic of Capricorn, you can divide Australia into two pieces. You've got the north and the south. And you can see from the perinatal statistics that I've put on the diagram that there is a vast disparity. You've got an increased risk of stillbirths. You've got a 2 to 4 times the risk of maternal death. And you've got an increase in preterm birth in the north compared to the south. There are many, many potential reasons for this. Firstly, the population is a very low population in the north compared to the south. In addition, there are not many perinatal services that exist within the north. And obviously, we need more perinatal specialists, and we need people to be able to cope and manage the extra morbidity and or prevention of mortality in these areas. My inquisitive nature at the start of my ONG training took me to Darwin, and I asked the question, but why? Why are there increased preterm births? Why are there poorer outcomes? And so we ended up cutting up about 192 placentas from locations all over the north that you can see here on the map. The majority were obviously from Darwin, but there was a significant component of rural and remote placentas from women delivering at Royal Darwin Hospital during a 3-month period. I sectioned, weighed every placenta and put them onto slides. And then Dr. Susan Arbuckle was blinded to the clinical outcome, looked at the placentas, and then she recorded her results. When we went and did an adjusted regression analysis, we actually found that rural and remote women and their placentas had higher rates of placental inflammation compared with metropolitan, and also there was no difference in ethnicity. So Aboriginal and Torres Strait Islander women had no significant difference to placental inflammation. It was actually those women that lived remotely, and of course there are a higher proportion of Aboriginal and Torres Strait Islander women who do live remotely in Australia. So that was a really interesting finding, and that sort of did shape the direction of my career from there. So remoteness has all of these different aspects. We have weather-related conditions, low population numbers, as I mentioned, high proportion of First Nations, in addition to food insecurity, which contributes to malnourishment, along with disparity in job opportunities and education, housing issues, sanitation issues, and then not to mention the significant and vast distances it takes for people to get to healthcare services, along with the lack of specialists and the lack of continuity, particularly in remote areas of healthcare professional staff. All of these aspects mean that probably remoteness is related to systemic disadvantage, and we can actually, it's difficult to measure and quantify, but remoteness as an entity itself could represent the actual cause of the disadvantage. So North Queensland, let's look at that, and that's where I am at the moment. So Townsville has, North Queensland has a population of 700,000. and 12.3% identify as Aboriginal or Torres Strait Island. 10,000 deliveries per year in this area, and 800 of those babies are admitted into the NICU in Townsville, and 27% are actually from remote or very remote areas. So that's 1/3 of babies. When we actually did an audit of extreme prematurity in Townsville Hospital, we found that there were significant factors, including BMI, smoking, a high rate of inter-hospital transfer, 60%, and then a higher proportion of First Nation mothers experiencing preterm birth and extreme prematurity. And when we went back and looked at their notes and saw that they had actually had a previous preterm birth, 90% of them did not have the interventions that they needed to have to prevent a preterm birth in a subsequent pregnancy. So these are potentially preventable. What about hypertension? We know that preeclampsia is increased in women who identify as Aboriginal and Torres Strait Islander. And we found that in some of the remote communities that we were visiting, up to 9% were affected by preeclampsia, compared with an overall rate of 2.3% in Queensland. When I first arrived into Townsville, I noticed that there was more eclampsia that I'd seen in 1 year in Townsville than I'd seen in my career in New South Wales and in my training. And this was 3 times the national rate when I did an audit of the eclamptic fits in the north. I've got a great honours student who has actually just finished her scoping review, which basically showed that the literature is heterogeneous and very limited when we look at comparisons between rural and remote versus metropolitan in terms of hypertension, preeclampsia, and outcomes such as low birth weight and SGA related to that. So we're currently, and her honours project is currently looking at the impact of remoteness on maternal and perinatal outcomes in Queensland, and we're looking over a 4-year period with over 240,000 deliveries. I want you to now just reset, now that we've talked about understanding why this is really important, is to actually put yourself in this mother's shoes. She's a mum of 3 children. She lives on Mornington Island. She's pregnant with her 4th, excited, unplanned, but very excited about a 4th baby. But what are the barriers for her attending a routine ultrasound and her routine pregnancy care in her maternity hospital, which is in Mount Isa, which is over 700 kilometres away from her? So her family commitments are very, very strong, and she often can't just get up and go. The financial impact of that is huge. The transportation to and from the airport and the hospital is something that worries women a lot when they're from out of area. Often women are okay to go and they're happy and they're planning to go, but then their appointments are cancelled because there is no accommodation to enable them to stay for the ultrasound and to stay for 3 or 4 days either side of their ultrasound. And then obviously they have the care of their other children, and sometimes women report that they don't have someone safe to leave their children with. And also those that are working mums, they have a loss of income for that entire week that they're away. I know that if that was me, I wouldn't go to my routine pregnancy ultrasound or care in another town 700 kilometres away. And I don't know how all of you feel, but that's how I would feel if I put myself in this woman's shoes. So what can we do about it? Well, we can get on a plane and we can go to women. And basically that's what this talk is about. And the story began about 20 years ago, well before I was ever involved. And it was a fantastic Queensland Health funded sonographer and midwifery team, Sue Bloomfield and Alex Gusden. And they together began a program by going to women on Palm Island and facilitating opportunistic care at the time of ultrasound. And over the years, it evolved into an obstetrician and a sonologist going, and that was me, and I was extremely privileged and honoured to be involved. We integrated and resided in a location where we worked with the local GPs, and we facilitated and worked with the Joyce Palmer Hospital on Palm Island, and worked with the visiting allied health professionals and Aboriginal health workers. Over time, we had more and more pregnancies, not enough ultrasound time, and so we approached Checkup Australia for further funding. And that funding gave us extra visits for ultrasound, but they also asked for me to be a gynaecologist. So I put my gynaecology hat on, and I do facilitate some office gynaecology while I'm there as well. And this is where the Care on Country program started. So within a few months of these extra visits on Palm Island, we were then called up by Checkup Australia to say that Mornington Island in the Gulf of Carpentaria wanted the same service. And so did Doomadgee, and so did Normanton, Corumba and Burketown. And so that's how we started this process. So you can see in that area that we've done and we've started our outreach, there's approximately about 200 births, give or take. And when we look at the perinatal statistics over the last few years, of those 200, 18 would develop preeclampsia based on the current statistics, and also 30 would have a preterm birth. And that just gives you a little bit of a context of what the patient demographic is like. So the aim of our program was to provide culturally safe care for women. We used ultrasound as a connector, and talking about connection, as Natalie has talked about, and reducing travel for routine pregnancy investigations, training local staff in both ultrasounds, early dating, and obstetric and antenatal care. And then also instigating primary, secondary and tertiary prevention strategies to reduce the chances of obstetric complications. We partnered with all these incredible organisations. The Palm Island Community Council has been a great supporter for us, and we've really enjoyed working with the team. TARS, we've started working with in the last 6 months, and it's been a fabulous working relationship. I'm still involved with Townsville University Hospital and Checkup Australia. The PHN are our funding bodies, and the Northwest as well, that we integrate with the Gulf of Carpentaria service. Our equipment is very to a certain degree basic, and we started off very basic, and we've increased our tech over the last sort of 12 to 24 months. We started off with a very simple portable ultrasound, and we use Starlink as our connectivity. And we basically upload images into Trisify, which is a cloud PAC system, and then that then drops into my Viewpoint so that I can then report using a Viewpoint software. And then we have a practice management software that is web-based, so it doesn't need to be connected to a server. The challenges. Connectivity was our biggest challenge, and it took us a while to work out that Starlink was the only way that we could get the images up to the cloud easily without delay. The equipment, often we didn't have gynae beds, and particularly when we started. We do now have gynae beds, but that was very challenging, and so we had to do a lot of MacGyvering in making beds more suitable for women during gynecological examination. And then we were met with a lot of excitement at Mornington Island that these were our ultrasounds and how proud they were of their ultrasounds. And I had a little giggle because that's what I started ultrasound on, the Sono site, and brought back lots of memories. But obviously we couldn't do morphologies on that. And then obviously the big wet, the cyclones, huge amounts of rain and flooding would often stop or delay our trips. And the age-old challenge, forever challenge of funding. This is our first trip in July 2023, and this was a lovely patient of ours who agreed to be scanned. And this was the resident ultrasound machine, which was pretty good in Normanton Hospital. It was an S8 GE machine. And so we were able to, with our connectivity to Trisify, use that machine to do most of our imaging, which was incredible. But obviously it didn't have any 3D capabilities or any updated fancy fetal heart settings. Then, with much excitement, after you saw the ultrasounds that existed on Mornington Island, they then purchased a Voluson Swift, and that's been a great source of excitement for the community because we now have a very, very high level, fairly basic machine, but it can do everything that we want it to do, and the girls love the 3Ds, so that's been a win. I wanted to show this. This is one of my favourite photos because ultimately we want the next generation of kids to become sonographers. And my pipe dream would be to have the kids grow into beautiful sonographers in their local communities and be doing their ultrasounds themselves, and having people like me and other MFMs reading their images and connecting with them. And I think that this is the pipe dream. And this little kid actually had a very good eye. And there's the pregnancy there. So this little girl did very well. This is what it looks like. 32 months now that we've been going, and we go once a month. We were increasing our visits up to fortnightly, but unfortunately the expense of that was too much. So we ended up having to then go to monthly with ad hoc visits if required. You can see that their weather events definitely disrupted some of our visits, but overall the general uptake has been incredible, and we're now seeing on average 40 to 50 women every month in the communities. Overall, with the Women's Health Circle, which is the parent company, we've scanned over 5,000 women in rural and remote North Queensland and Northern Territory. We've performed over 9,000 ultrasounds in the care on country, so delivering this service to women on country, that's now up to over 1,000 ultrasounds. We've done over 782 first trimester screening and preeclampsia screening, which has been very exciting to bring that to the north. In terms of the classification of some of the ultrasound findings and referrals, about 60% of what we do in community is absolutely normal and doesn't need any action and can have routine care. The rest of it is complicated and does need some input, sometimes a formal MFM input, sometimes it needs a high-risk obstetric hat and a maternal medicine hat. But we've had caesarean scar ectopics, we've had a complete molar pregnancy, which was up to the umbilicus before diagnosis in the middle of a remote community, and she just started bleeding the day before. We had a baby that nearly didn't make it, which had an acute placental insufficiency at 35 weeks, and we had to fly off, and that baby is doing very well. We've had mums with coronary artery bypass stents. We've had warfarin, mechanical valves, goiters, thyroid cancers causing obstructive tracheal symptoms. We've seen lots of threatened preterm labour, shortened cervixes, and been able to initiate progesterone and ongoing monitoring and counselling. We've been able to identify women at risk of preeclampsia, initiate aspirin and further growth scans. We've picked up some complex cardiac anomalies, renal abnormalities and limb differences. And we've also had a live ectopic remotely, which we were able to, with Mount Isa, amazing management, able to get that patient there within the day, and she was operated on that night and had a very good outcome. And we've also done lots of assisting with termination care and miscarriage management in the community and helped to keep women in their communities for those procedures. What's the impact on health outcomes? So we've done some audit data and we are going to be presenting this further on with more detail at a later date. But overall, we've had a big reduction in low birth weight infants, up to 50%. We've had a reduction, and that's a small reduction in fetal growth restriction. We've had a small reduction in preeclampsia, a moderate reduction in preterm birth, and we've also increased the detection of placental insufficiency, which is a major cause of stillbirth. Thanks to Townsville Hospital for giving me some data just to add to the story. And this is looking at just Townsville, and we've started a new program with the Townsville Aboriginal Controlled Health Organisation, and we've seen a steady improvement in the local Townsville birth weights since women have had culturally safe access to ultrasound and screening, pregnancy screening. So that's been great. The impact on the health services. So we've had a reduction in planned commercial travel to routine appointments, which has been a significant amount of money. We've minimised delays in the setting of a high-risk result or an abnormal ultrasound. We've seen a reduction in emergent error medical retrievals, which again is a big cost to the healthcare system. And we've also been able to initiate and start primary and secondary prevention strategies, which is in line with what metropolitan women receive as their standard care. So we've also been so lucky, and a big shout out to KPMG, who have done a formal economic analysis, and I was hoping to present this today, but we haven't got the official full sign-off yet, but they said I could just introduce the concept that this is coming. And they've looked at all our costings for the program, which over the last 2.5 years has amounted to about $1 million, which includes staff costs, consumables, diagnostic equipment and travel. And this is definitely not part of their analysis, but this was what I had put together prior to KPMG doing a formal economic analysis. But we're at least saving $3,000 per patient per travel per scan. So you can imagine how much we have saved the healthcare service. So that's about $3 million on its own. When we look at the social bank value calculator of reducing stress, reducing financial burdens, improving women's confidence in the service locally, that has been attributed to about 1.5 million. And then using some of Prof. Newman's cost analysis in relation to preterm birth, we've extrapolated it to some of our numbers, and we're estimating about $1 million saved in just that. And that's very conservative, but we're looking at that plus more in terms of the cost savings. So it's highly significant. In terms of our evaluations, we've had great evaluations, and the women just absolutely love the service. You're going to hear about this in a minute when I put on our videos. 100% of the women received the help that they wanted to, and they felt listened to, which is exactly what we want. So we are fulfilling some of the closing of the gap criteria as well, and the KPMG report outlines this in more detail. So to summarise, we've improved the access to routine pregnancy ultrasound and care. We work collaboratively with a whole range of different people. We do training and education, capacity building in local communities, and our benefit to cost ratios are highly significant. What does the future look like? So the yellow stars are what we're actually currently doing, and the purple stars are where we're actually liaising with new communities to look at whether we can expand the project and the program out to their communities so that more women can access their service at home. Where to next? Sustainable funding, of course. And we've been very lucky, and a big shout out to the North Queensland PHN who have come on board for another 12 months with us, which we're very excited about. And part of that funding is going to additional communities. So that's what the next sort of 6 months is going to be. We'd like to have a larger team. We have a visiting physio, which is wonderful. We have the midwives that come from Mount Isa and join us on our outreach. But I would also love to have nursing and a pharmacist as well, because there's no pharmacists in any of the remote communities. And a lot of what I end up doing is facilitating medications and teaching women about the medications. So I think a pharmacist would be absolutely paramount out there to make sure that women are getting the medications in a timely fashion. We're partnering with the communities to do prospective research projects, and that's ensuring data sovereignty as well. And I think that that's where we always want to be, is that this is driven by the communities, for the communities, and we are there to assist and help, but we want to improve their local capacity. And we also want to do education and training and upskill as many of the local staff in an early dating scan so that they can contact us and say, I think she's about 8 weeks and we want to book her in for her nuchal scan and preeclampsia screen at 12 weeks. And that's where I'd love to get to.
Great. Thank you.
Cecilia, thank you. It's an extraordinary program, and it sort of beggars belief that even that back of the envelope calculation of cost effectiveness, that you are having to live 12 months to 12 months.
Yes.
What's the sustainability funding proposal? What does it look like?
What does it look like? Well, we were waiting on the economic analysis.
Yep.
Yeah, so we could go to Queensland government and say, we would like to have recurrent funding. We would like to go to more communities and be able to actually try and use this as a model for women that don't have any access to ultrasound in their hometown. And I think that this has all proven that this is acceptable by the communities. It's cost effective. We're helping in terms of the outcomes, reducing morbidity. And I think overall, I think it'd be hopefully the Queensland government will come to the party and fund us recurrently. I'd love to see it develop into something like Deadly Ears, where you have a set program with set clinicians going to set communities, and you have a rotating system. And I'd love to see something like that for the future for women's health.
Absolutely.
Yeah.
There's a question here, with closing the gap funding, why isn't this available to all Indigenous communities?
Oh, it's a great question. I don't actually think that, I think that a lot of pregnancy-related care and ultrasound-related care is all state-based and within the health systems. But I agree with you. I think that this is something that is closing the gap. It's federally funded. We should be thinking about it more on a national level rather than an individual state level, because our states are so pushed financially with delivering basic hospital care. And so this preventative type of perinatal care that we're trying to, deliver is something that I think, the federal government should really look at. And I think the economic analysis will prove that. I think all the work of the National Preterm Birth Alliance, Stillbirth Alliance, all of that incredible work in a national forum is going to shape perinatal care. But particularly we need to be focusing on rural and remote women. I think this is where I think, we've proven that something so simple and so cost effective can work. This is where we need to be. Yeah.
Cecilia, thank you. Just a brilliant talk. I'm conscious that we're coming up to time,
yes.
But it was just a brilliant talk, and I suspect that you'll all agree it's been a fascinating twilight tonight. I think we've been asked to step in other people's shoes, and in each of those shoes, those people are saying, don't leave us behind. A fantastic summary from Kelly about one of the groups in the population who are most likely to not access medical care, and how do we reach out and help to bring transgender people across the bridge to be able to get the pregnancy care they need. We've heard from Nat just a fascinating perspective on what it's like for a baby to live in NICU, and I think it's probably blown all of our minds in a small and a big way, and just the interventions that can and should be offered to make sure that the person who is at the centre of NICU care, that their experience is fundamentally embedded in connection. And then finally, we've heard about we all understand as Australians, and some of you are from Canada and others also understand this concept of very remote care, where there's very low density population, but where it's a population with relatively small numbers, but who can so easily be left behind. And what we've heard from Cecilia is that it doesn't have to be like that. It doesn't have to be 700 kilometres driving in each direction and thousands of dollars and fragmentation of care, and sometimes just opting out of care altogether. That there is an opportunity for us to provide meaningful in-reach, and that you can see that it can be done cost effectively, and it can reduce the major obstetric syndromes that, as she said, primary and secondary prevention of those things are the bread and butter that everybody expects in metropolitan and local regional care. And I think tonight has really popped my equity glasses on. I think we're all looking at equity and just salute the three of you for the way that you are contributing to make better care for everyone and to make sure we leave no one behind. So thank you, Cecilia. Thank you, Nash. Thanks, Kelly. Thanks to Ali, to Bella, to everybody who's joined us tonight. And we look forward to seeing you for Global Obstetric Journal Club about Prevent PE. That'll be next Wednesday. We'll be coming to you from Cape Town. And then fetal growth restriction, what all the international big dogs think about that. And that'll be from Perth in 4 weeks' time. So thanks, everybody, and good night.